Bismillahirrahmanirrahim. Assalamu alaikum. The first ECG, we start with the rhythm. We can find the P wave in the lead 2. There's a sinus rhythm. Then the rate, there are about 3 boxes in between. So the rate is between 90 to 100 beats per minute. It is better to give a range than to just quote a figure. Then we come towards the axis, lead 1 and AVF. Lead 1 is more downward and lead AVF is upward. So this is right axis deviation. After looking at the rhythm, rate and axis, we start looking at the QRST. If you look at the QRS complexes, they are relatively broad because the normal width of the QRS complex is about 2.5 boxes, and if we look over here, there are about 3 to 3.5. So these are broad QRS complexes. Afterwards, we comment on the ST segment and the T wave. So there is T wave inversion in lead 3. There is T wave inversion in AVF. There's T wave inversion V1, V2, V3 and V4. Apart from that, we can see ST segments are normal, but the last thing that we see in the ECG is the R wave progression. If we find a dominant R wave in lead V1 which is not present in the normal ECG, along with the persistent S wave, either it's right ventricular hypertrophy, but if you are able to see this M pattern in lead V1 and slurred S wave in V6, this is right bundle branch block. So a bonus point for you people, if I say to you that this patient also has murmur and on ECG you are able to find the right bundle branch block, then the most probable diagnosis is ASD. So what is the final assessment of this ECG? This is a sinus rhythm with a rate of 90 to 100 beats per minute with right axis deviation and broad QRS complexes with RSR pattern in V1, and also we have a wide slurred S wave in V6 along with T wave inversions in lead 3, AVF, V1 to V4 and normal ST segments. ECG number 2, we are able to find P wave in lead 2. So this is a sinus rhythm. If we calculate the rate, there are about 2.5 boxes, so the heart rate is between 100 to 110 beats per minute. Both lead 1 and AVF are upward, so their axis is normal. Then we start looking at the QRSTs. No Q wave, R waves are normal, T waves are normal. Here we can see that there is small Q wave in lead 2. So if we are finding a Q wave in lead 2, we have to look for all the inferior leads. There is Q wave in lead 3. There is Q wave in AVF. Let me revise for you that lead 1, AVL, V5, V6 are lateral leads. Lead 2, 3, AVF are inferior leads. And lead V1, V2, V3, V4 are interoceptal leads. So we are able to find Q waves in inferior leads. Then we keep looking at the Q waves and the ST segments. So look over here. Prominent ST segment elevation in lead V1, V2, V3, V4, V5 and V6. So all the interolateral leads. What we have over here, that there is basically the old inferior wall MI, because the Q waves represent the old MI and the ST segments represents the acute interolateral wall MI. And if I say that the patient has got streptokinase in his previous admission because of this old MI, will you give streptokinase again to this patient? And another question is that does this patient fulfill the criteria of thrombolysis? Yes, there are ST segment elevation in the chest lead which is more than 2 mm. So this patient meets the criteria of thrombolysis. What is the criteria of thrombolysis? That there is elevation of ST segment of more than 2 mm in chest leads, more than 1 mm in limb leads, and if there is new onset left bundle branch block. So, if this patient has got streptokinase in the previous admission, then can you give streptokinase to this patient? The answer is no, because once the patient gets streptokinase, there is development of antibodies against streptokinase, and it is very dangerous to give or reconsider streptokinase in this patient. So, we have to consider either alteplase or retiplase, but obviously the choice is percutaneous intervention. In this third ECG, we are able to find P waves. So there's a sinus rhythm, and if you look at the rate, only two boxes, though the heart rate is from in between 140 to 150 beats per minute. Lead 1 and AVF both are upwards, X's are normal, QRST normal, QRST normal, complexes are normal over here. But one important thing that we can find over here is that we can see that there is basically a biphasic T wave. यहाँ पर आप देख रहे हैं, आपको inversion मिल रही है, यहाँ upward deflection मिल रही है. तो biphasic जो है T waves you can find in the inferior leads. Look. Apart from this, if we look at the ST segments, we can find that there's slight ST segment depression in V1, V2, and V4. So whenever you are finding this sinus tachycardia with these non-specific ST segment depression, and if it can be correlated clinically, always think about pulmonary embolism. In pulmonary embolism, we can simply have sinus tachycardia only, apart from these T wave changes and ST segment changes. Now, in this last ECG, first of all, the rhythm. If you concentrate, you will see that the P waves here is a P wave, but here another P wave is just mixing with the T wave. You can see a very broad T wave over here and a P wave over here. So basically these are two P waves preceding QRS complexes. So the rhythm is atrial flutter. You can find it very well in the lead 2 as well. Sometimes, like I personally feel it difficult to pick atrial flutter. I don't know why. Halanki, when you look or you read atrial flutter, the ECGs that they provide, they're very easy to get the flutter waves over there, sort of type. But the thing is that in real ECGs, it is very difficult. For me personally, it is very difficult to identify the atrial flutter. So what I have made for me sort of shortcut, that when you find in the lead 2 you can find a P wave, but if you see that the T wave is very broad, so these are basically P wave mixing with the T wave, so these are two P waves. And when we find two P waves preceding the QRS complex, this is atrial flutter 2:1 conduction. Then we again simply we have to calculate the ventricular rate, and you can see the axis, that the axis is normal, both lead 1 and AVF are upwards. And if you look at the rate, only 1.5 box, so the rate is ventricular